Peter Fleming, thanks for joining us on eHealth Space TV.
Pleasure. Thank you for inviting me.
How would you clarify what NEHTA's mission is?
So NEHTA was established almost 6 years ago now by the Council of Australian Governments. And to quote some of our directors, they talk about the rail gauge scenario and ensuring that we don't end up down that process. So it's very much around putting in place the standards throughout the nation that allow us to operate in one healthcare community, and also putting in place the infrastructure to leverage that. So, there are key components of infrastructure that only government can deliver: secure messaging, the NASH services, the SNOMED services around clinical terminology, etc., etc. So it's getting those components in place. The level above that, certainly the standards around things such as discharge, referral, medication management, pathology, etc., are all key, both from a clinical standards perspective and a technology standards perspective.
So let's go to the PCEHR. The government this week said that 95% of patients they expect will have access to the PCEHR in 8 years after the scheme launches next year. So do you think that is too conservative a time frame?
At the end of the day, our job is to implement government policy. And clearly when you look at how complex this is from a change management perspective, what the government is looking at is all of those components. There are over 800,000 people that work in health.
Just the industry alone?
Industry alone. It touches every Australian. There are key groups that clearly we want to work closely with. Aged care, the Indigenous population, those with chronic disease, mothers with newborns, they are groups that will take major advantage from them.
You think that's an okay time frame, was what I'm hearing you say?
Absolutely.
Yeah. All right, so how quickly then do you expect people will adopt it?
Firstly, one of the key messages I'd like to leave is we could implement an electronic health record tomorrow, but unless we've got the foundations not quite tomorrow, but unless the foundations are in place, it will break. We will have data integrity issues, etc. So the key with the electronic health record is getting those foundations in place, using the identifiers, using secure messaging, using NASH services, so that what we have is a safe, secure environment. It's also understanding the change management components. We could implement things in silos, and that would give us some benefit. But if we're going to maximise the benefit from this for the Australian population, we need to take an end-to-end holistic perspective, understand the workflows and how that changes over a period of time. So even at the most basic level, if you're my GP and I come along to you and say, Peter, I'd like you to see Specialist A, the way that operates today is you will give me a letter to take to that specialist.
That's right.
He or she will open it up and there's a process that starts. In the near future, it will be electronic. And as part of that, we have standards around what's required there in terms of the information that will flow through. But if you then project forward a little bit further, okay, so that is a big leap forward, but project further. If I've chosen, and I will, to have an electronic health record, and you say to me, Peter, I would like you to see Specialist A, the reality is I would like Specialist A to see that electronic health record. That changes the perspective that he or she has. They can get in and have a look at the MRI or the history. And so that the workflow changes quite substantially.
There are a lot of details that still have to be worked out before we even talk about adoption rates. Is that what you're saying to me?
So what I'm saying here is we need to ensure that our adoption takes account of all that and moves in a way that as a society we can move with it. But in terms of uptake and what I expect, we are working with every state and territory government today, and they are making changes in their environment to utilise components of a NEHTA stack. So we will try one thing in a state before we roll it out nationally, etc. And we work through collaboratively with those groups. In fact, Tassie has just recently implemented the HR service in the background of their systems and starting to build that up. Close to doing that with ACT, we're running data profiling exercises with a lot of the other states. Northern Territory with South Australia is moving towards using the secure messaging standards, etc. So we're doing things with each of those areas. Victoria, AMT, has been implemented in a couple of hospitals now, is rolling out. That's part of that program. We're working with the public sector, key component, but it's also how do we then implement it in the wave 1 and 2 side. So if I just took wave 1 as an example, the first group, where we have GP partners up in Brisbane, we have Hunter here in New South Wales, and East Melbourne down in Victoria. Those three groups are working very collaboratively together, and the intention there is we're not just working with GP divisions. part of the program that they're driving through is within their local environment, where they're linking up. They've agreed to a series of objectives that we're working together on to implement that NEHTA stack. And that means over a period of time, those areas will see that operating in their local GP practices, through allied health, etc., over a period of time. As part of that process, we've created a vendor council where a number of vendors are working with us to change their systems to allow for these things. And we have agreements in place with the 3 states that they're in that they will change their system. So it's one thing to be able to say, look, at a local level, I, the GP, can receive a compliant discharge summary, but we need to make sure that the hospital is sending you a compliant summary. So those links are being tied very neatly together at the moment so that we get that level of dialogue. Part of that process is clearly it's one thing for us to work with the stakeholders and say, here's the specification or the standard. It's another to see it operate in real life. So we do know, it's why we have the vendor panels, that there will be changes that are required. So there's a process.
It sounds to me like you're hoping for sort of like an organic development or growth of this from a GP level. But I guess I'm also asking about the public perception and the public adoption, the programs that will, essentially we'll see in the national newspapers, we'll see this massive push. And I guess that's what we've also been waiting for, to find out how's that going to work.
Now, in terms then of the change management and the public relations that go with that, clearly there will be a lot of work, and there is, at those local levels. Now, one of the things, as managing agent for the PCEHR with DOHA, we have a number of partners we work with. DOHA are in the process of appointing a change management partner, and they will work with us, not just to see what's required at the local level, but also at a national level in terms of advertising. And you'd be well aware, there's a number of initiatives underway now, there's a number of websites and publications, etc. But clearly we do need to take that to a level with appropriate timing, so that, you can move too early on these things and you can move too late. So it's trying to get that expertise in to help us through that process.
Okay, so once the PCEHR is up and running, what specific measures will you use, or what are you looking for that will gauge the success?
The key for us is delivering and the benefit. Now, as part of that, we want to build benefits realisation into this environment from day one. And that means inculcating it within everything we do. So as we say we're going to do A, B or C, what are the benefits and how do we measure that? So one of our partners is a benefits realisation partner. So within the context of what we're doing as DOHA's managing agent, there are a number of partners that we're going to work with. Benefits realisation partner is going to work with us not only to define what benefits we expect from every component of what's being done, but to help us build that into the system so that we have direct loop feedbacks. We expected to receive a benefit of A. Have we achieved that? If not, why not? What do we need to do to adjust? So that is part of the process. Right. Now, putting that in context, there was a report by Booz late last year that indicated a number of benefits. They indicated once these systems are in place, and I am paraphrasing here, 5,000 lives a year saved. Okay, that's substantial. If we compare it to road toll deaths or whatever else, and if we compare it to road toll, we know that if someone dies on the road, there's a number of injuries also. For every person that dies, there's other people's lives who are severely impacted. The same applies here. So 5,000 lives, huge number. 7.6 billion per annum in savings. So,
and of course, all the metrics to calculate, in a proper fashion, how that would actually work. Yes.
So it's very important to us to be able to say those savings or those lives are directly attributable to these actions. And clearly there's a lot of work, because this is a complex environment. Because if we are to move down the path that we need, we have to be able to ensure to the Australian public, to the government, that they are achieving those benefits.
What about other even more simple metrics, like the fact that it's up and working? The records actually do get exchanged, that there's a quality of service that's provided. How will you measure those things?
So all of those components are clearly going to be part of that benefits realisation program. And you're right. So even if I look at the HI service, which is still in its very early days, there are a series of metrics today where we know exactly how many HI numbers have been issued, how many provider numbers, how many organisational numbers, the number of transactions that occur every day, the number of hits on the service. So absolutely those numbers are being monitored and measured on a daily basis today.
And is the government linking any of those success metrics to funding? ongoing funding?
Ultimately, I am sure that will be part of the program.
Has the government said, well, these are some of the metrics we want to see and therefore you've got to hit them? Or?
I absolutely just take that as part of the implied expectation. That clearly, for any funding, it doesn't matter whether we're talking public or private, there is an expectation of return on investment. Right.
They haven't said specific things? I mean, they haven't said number of lives or anything like that?
No, but I'm sure as we work through, they will be discussions that are taken into account.
Okay. Still just on the PCEHR, what do you think are the biggest risks to the project?
I think the key risk for us in the short term is just the amount of work that needs to be done in a relatively short period of time.
Right.
That put in context, though, I think it is wonderful that we have a stake in the ground.
Yep.
The fact that we have a stake in the ground has allowed us to mobilise, not just within NEHTA, not just within DAHA, not just within the jurisdictions, but everybody else that's touched by this. But it does actually allow us, when we go to the market, to say, look, here is the vision. This is what we're trying to achieve. This is what it means for every Australian, and it is part of that process. The reality is, this is actually quite different to most IT programs. I have been quoted as saying the technology is easy compared to the change management. But if you look at the way it's broken up, there are many components to this. And each of those components offers significant benefit in their own right. And that's actually part of the risk mitigation. That, if you look at the discharge referrals, etc., they are discrete projects in their own right. We certainly understand the interphasing that's required as part of that, but it's also part of the mitigating circumstance.
Okay. Let's talk about the 12 wave sites. Clearly that's been going on for a little while now. How's the uptake, and is it what you're expecting?
Yes. Look, the reality is, as you're well aware, we went through a detailed process with DAHA to select the sites. So in terms of the detailed plans, absolutely, they're locked down. So that's a reality. Obviously, wave 1 slightly ahead of wave 2 in that context. But no, we have detailed plans for all parties. And obviously with this, final deliverables are very much by that June 2012 date.
Of course. Now, what about the technology side? I note that there are a number of different types of solutions being rolled out.
Correct.
Do you feel like you've got a good enough spread to give you a sense of how well this will work at a much larger scale?
So one of the things we will release very soon is a series of design documents, architecture documents, etc., that show how this piece is together. And if you think about it in the context of what we're doing, the concept of operations has been released. In fact, it's now the 1st of June, so the reality is that feedback on that closed yesterday, and I know there's been a number of submissions there. We'll go through that consultation, but we're now moving into some of the more detailed design. That said, so firstly at an architectural level, there's a lot of work being done to make sure that people understand how this ties together.
Yes.
Now, that said, clearly we have a number of partners in this area. On the NASH side, which is a COAG funded project, IBM has been announced as the provider there. Another key project is NIP, the National Infrastructure Partner. What we're looking for is a partner to help or to build the infrastructure, whether it be repository services, template service, indexing services. And part of that, clearly they will do it within the construct of the architectures and design, do it very closely with all the other key partners. But because we have those architectures, we're quite confident that they will understand how these things link together.
Right. Is these 12 wave sites, are they trials or are they implementations?
Oh, they are implementations.
Right.
So if I just took the wave 1 sites as an example, the population catchment area of those 3 sites is 1.6 million people. The agreement off the top of my head is that we're talking a number of hundreds of thousands of people that will be linked in as part of that process. The type of information we expect to get from these early implementations is not just around the standards and the feedback loop into the software applications, but it's also very much around the work processes, the implications on you and I as patients, and how that comes together.
Okay. But is there any other bases that you'd like to see
Look,
developed?
Not at this stage. Clearly there's a long-term view in terms of how this should come together in the next stages, but there's also a limit in terms of how much, not just we, but the country as a whole can digest.
Is there going to be a wave 3?
There has been no decisions on that at this point in time.
Indeed. And just finally, what's NEHTA's ongoing role, do you see?
It's actually interesting. I have a number of different thoughts on this. I think time will tell NEHTA is a transition authority. One of the things we try to do with everything is ensure that there's a natural home. There comes a point in time we say, this actually doesn't exist today. What might we do there? And decisions will be needed on that front. That said, I mean, there is no doubt that there is a role for NEHTA for quite a long period of time into the future.
Well, particularly when you're talking about supporting the technology stack. That's got to live somewhere, right?
Correct.
Okay.
Correct.
In closing, NBN is one of the biggest proof points for e-health, and I guess I'd like to know, are you seeing any upside benefits from the early rollouts in Tasmania and also in New South Wales, New England? Are you getting any feedback to that effect?
For the initial implementations of e-health, we can operate on existing bandwidth.
Yep.
As you project into the future, we need substantial bandwidth. Okay, that's where NBN comes in.
Of course.
Now, that said, by June 2012, we'll be in a position where we can say electronic health records available, etc., etc. And so we're looking at, okay, how do we then leverage this other infrastructure that's in place? So we're having close dialogue with the NBN team at the moment to see how that plays out.
Yeah, and just on that though, you'd actually going to need a lot of quality of service and all sorts of network management to do the sorts of things you were speaking about. So,
correct.
Who's going to own that part of it?
Oh, look, from my perspective, the quality of service is very much in the court of NBN
right.
and their partners. The bandwidth is important. In the short term, the quality of service is absolutely imperative.
Yes.
If you happen to be in the Tiwi Islands or in a remote community in Northern Territory, and you're very much dependent on these health services being delivered, the last thing you want is to have links going down.
That's right.
So it's very much important.
Well, it'll be interesting to see how it all plays out. Peter Fleming, thanks for your time today. I appreciate it.
And thank you very much.
Thank you.
Pleasure.
Bye.